I would like to invite all audiences to type your questions in the Q&A tab in Zoom, or if you would like to comment in person, please raise your hands via the Zoom tab. So we already have one question, and from Jeremy. The first question goes to Afram. So do you have any resources on ceftazidime infuser stability greater than 12 hours? So Afra, are you able to comment on this one?
Hi, Jeremy. Yeah. Well, I mean, I understand that this is one of the topics that has been widely debated about. Unfortunately, well, at this point of time, we still run the ceftazidime for 24 hours. There are some papers that suggested that maybe that you have used an insulated bag to maintain the temperature of the infuser. So I do not have any specific resources to share with you at this point of time. Maybe I can get back to you in a bit. Yeah. So that's one of the ways that we do it here in Malaysia. Yeah. I hope that answers your question.
Yeah, thank you, Afra. So I may be able to comment on this one as well. So we actually have done stability tests for ceftazidime very recently and the paper is under consideration. So probably watch out for a new paper maybe in the coming few weeks from JSAMR, and that should be able to answer any of your questions on the stability of ceftazidime during 24-hour continuous infusion. So I would go to the next question. Mark, so you have one question for you. Are you able to take it off? So patients become increasingly complex, and with comorbidity, do you think it would be appropriate for OPAT programs to work in coordination with hospital at-home units?
Yeah, absolutely. I think that is the direction of travel. I think the thing that we're seeing, particularly in the UK, is you've got a bit of a dynamic going on, haven't you? You've got OPAT services with specialist infection inputs. You've got hospital in the home that's starting, but sometimes those don't have infection specialists always running them. And it's how within the UK we link the two. So I think the direction of travel is very much these two things are going to interweave, and it's how we make sure we've got a real opportunity to interweave them at the moment. Unfortunately, our systems aren't set up for that, and that's why these active discussions are taking place. And so I'm really enthusiastic about it. I think we've done so much within 30 years of setting things up. We've had a seismic shift in the way we operate OPAT services within the last couple of years, and there's really huge momentum into how we can operate differently. We have to operate differently, and it's just a matter of getting those funding streams in place. But there is support to make that happen. But I fully agree that is the direction of travel this is going.
Yeah, thank you, Mark. So if I may ask one question as well, so maybe to David. So we know that patient selection criteria is one of the hot topics in OPAT, in HEAth in general. So we know all the challenges in selecting clinically stable patients that have adequate social support and are safe to manage outside the hospital. So it's very interesting to see that you've suggested the use of AI technology in patient selection, perhaps in standardization of patient selection criteria. Do you have any experience on the use of AI? Are you able to comment on this one further?
Yeah, I think this is one of the main applications of artificial intelligence in our field, and I think is one of the ways we should advance. We are working. We presented it last year in the World Hospital at Home Congress in an algorithm that can help us choose those patients in hospital patients that can be good candidates. In fact, it's well, we have a lot of experience in this. We have a lot of data on which patients are going for hospital at home, so it shouldn't be too hard to give this data to an algorithm, and so the algorithm can decide for us. Still, it's technically difficult because you need to find the right person to give you the technological support. And still, when you have this algorithm going on and working, you still have this, human factor that you arrive to the, I don't know, cardiology ward and they tell you, yeah, okay, but I prefer the patient to stay for a couple of days more. But I think it's a good leverage you may use to increase your program or to be sure that you are not leaving behind any patient. But technically it's not easy and we are still working on it. I hope we can provide some more data soon enough.
Okay, thank you. So another very interesting point that I noted from all the speakers is the application of technology, especially telemedicine in OPAT practice. So one of the challenges in telemedicine, of course, is in terms of privacy and data security during virtual consultation. So do you have any experience on this? Perhaps maybe Mark and David can comment on this one.
Yeah, sure. So within the National Health Service in the UK, we have secure networks for the telemedicine. So you sort of log into a national domain, and we log in as well, and it's seen in a very closed environment. So you can't get into it elsewhere. So we don't have problems with that perspective. People dial in, you see it's almost like a virtual waiting room, and then from the virtual waiting room you see them, they come into clinic and you see them face to face. So and the beauty of that is you can actually do it on your phone. That's okay, because you're part of that virtual network and secure network.
Okay, thank you.
In our case, something similar. We don't have a national system. We have a regional system, and we created for telemedicine. We created our own home solution. So it's quite the same. We access to a secure website and patient access through this secure website. So we really don't have to deal with safety issues. I think what is important in telemedicine or in remote monitoring of patients is to be sure about what are you going to monitorize at home. What do you need to monitorize at home? Because we've seen many companies approaching us with different solutions, and they don't really answer to a necessity. They sometimes it's just getting technology in the home of the patient just because it's new and fancy and shiny, so you really need to be sure about what are your needs, what are your patients' needs. Also ask your patients what they need to feel safer at home.
No, great, thank you. So maybe one question to Afra. So as an emerging program, so have you seen any cultural or societal attitudes impacting the implementation of OPAT? So I note in some cultural contexts that there is a stigma and a misconception in home-based treatments. So have you seen any challenges on this one? And then what strategies have you used to implement OPAT in your settings?
In Malaysia, you mean? Yeah.
Yeah.
Cultural impact. I mean, so far, we've not had any particular issues in terms of cultural. I mean, in terms of how we recruit our patients. I mean, it's very much straightforward in terms of the treatment of an infection. So yeah, I mean, yeah, usually when we see a patient, I mean, of course we have to see their acceptance of the program, and so far I don't think there's any significant restrictions or issues with that. I think OPAT is a service that is quite well accepted here in terms of from all the patients that we've treated in Malaysia. Yeah. Yeah, I mean, in many of them, I mean, we know they are happy, but I